We're gathered here today to really talk about moving further upstream. And what we're hoping that you'll gain from today's webinar is a better sense of how MLPs are in fact well poised to identify those opportunities to advance health policy for entire communities, not just the individuals. We'll show and talk about some examples of the types of policies that do result in these persistent health inequities and barriers to access to justice. And then we'll talk about opportunities for MLPs to engage in some more policy-driven initiatives that really leverage those myriad stakeholders in the community in bold efforts to remove systemic barriers and really amplify the impact of your MLP interventions. You're going to hear first from, I'm starting from bottom right, Ann Mangiameli. She's with Legal Aid of Nebraska and does the Health, Education, and Law Project. Keegan Warren-Clem is, sorry, just have pop-ups on the screen. Apologies, you all. We're 14 months in, so bear with me, apologies. We're also joined by Keegan Warren-Clem, and she's a dual appointed adjunct professor at UT School of Law and McCombs School of Business. After Keegan and Ann speak, then you'll hear a small discussion, and then we'll transition to hearing from James Teufel, who's Associate Professor and Director of Public Health at Moravian College, and Rebecca Sandefur, who's Professor, School of Social and Family Dynamics at Arizona State University. And then I'll go into the discussion with them. Each of these panelists are going to talk a little bit about what you know in terms of problems existing with regard to health equity, but then offer some more emerging solutions or solutions that you may not engage in as much that are really driven by policy and regulatory initiatives. All right, so with that, we're going to hope that technology works for us today. And I'm going to first transition to our first speaker, Ann Mangiameli.
So I'm going to start talking about Medicaid Waiver. And for those of you who don't know what Medicaid Waiver is a way that individuals who may be above regular Medicaid income and asset guidelines, if they have a child or they are an adult who is so sick that but for Medicaid paying for services to come into their home, either the child or the adult would end up in a nursing home or a skilled nursing facility of some sort. So Medicaid Waiver, the name itself means that the government is waiving the income and asset guidelines in order to provide services for a child in a home. And in order to be able to prove that, and I can't see my entire slide. There we go. No, now I'm going back. Oh, I'm all over the place. Oh my goodness. Okay. In order to be able to prove that, you have to be able to show that that the person has basically medical needs that are to the point that if they weren't eligible for Medicaid, they would end up in a nursing home. And I only bring that up so that I can then explain what happened in Nebraska. Now let's see if I can do this. I don't know what I'm doing here. There we go. Okay, so how the problem began. There was a court case in 2015 called Murray B. We all just call it Murray B here. And in that case, there was a very, very sick child who had been getting Medicaid waiver services for years. And suddenly, the Department of Health and Human Services determined that they were no longer eligible for services and that their condition had improved. They based that upon the Medicaid waiver regulations, but they came up with this tool that they were using only for childhood disability Medicaid waiver cases. It was a tool that they claimed was based on the regulations, but it was one that they just came up with. The quotes that I'm showing you are what the Supreme Court of Nebraska said about that case, which is that children who have profound disabilities were basically being kicked off if they could walk, transfer, see, or hear. So kids that were profoundly ill, and this particular child, her condition had not improved at all. They just started using this different tool, so they kicked her off. What the Supreme Court also said was that the department, by using this tool that they had developed, were arbitrarily placing a far greater burden on disabled children. What the Supreme Court really came down to was they said that the regulations of this tool that they were using had not been promulgated as a rule. Basically, they didn't follow the rules correctly, and not only were they using a more difficult way for children to be found disabled than adults, but that they had not promulgated this properly as a rule if that's what they were going to do. DHHS seized on that, and instead of learning from this case that they were putting an excess burden on children, they promulgated that tool that they were using into their new regulations. So they made new regulations that followed this tool that they were using that the Supreme Court had said is horrible. But for some reason, they ignored that part of it and they promulgated these new rules. As a result, what happened was it was more difficult then for children under the new regulations to be approved for Medicaid waiver than it would have been for an adult. So these are some of the news stories that were being done as a result of these Medicaid. And I was going to put, different things in here, but this really sums up what was happening in Nebraska as a result of these new rules. An estimated 174 children were no longer going to qualify for benefits. They were no longer going to be able to have services within their home as of December of 2018. And they really went into effect just January 1st, 2019. There was another headline that I didn't add that said that children's families were begging the Department of Health and Human Services to change the regulations back to what they were. So how did we get involved? We have a partnership. One of the medical legal partnerships that we have here in Nebraska is with Children's Hospital Medical Center. And when I got a call from one of the social workers who said, oh my gosh, all of our families are saying they're being kicked off Medicaid waiver. We don't know what to do. And that is how the problem first came to our attention. They referred over 5 Medicaid waiver cases, kids that were being kicked off of Medicaid waiver, and we appealed all 5 of those denials to our district court in Lancaster County, Nebraska. In addition to that, we started having phone calls, conference calls with other advocacy groups that represented children with disabilities across the state. So we were having these conference calls with ARC Nebraska, with Disability Rights Nebraska, with Appleseed Nebraska. All of these advocacy groups were having these conference calls trying to figure out what is the best way to deal with this. Senator Howard, who's one of our unicameral senators here in Nebraska, was also very interested in this. So one of the advocacy groups was dealing directly with her. So in addition to us taking just the cases, we were strategizing with other groups. And that's how most of it got to the media and it really picked up. We were successful in winning all 5 of the Medicaid denial cases. All 5 of those were overturned. And as of December 20th of 2000, or December 23rd, 2020, DHHS, they first hired someone, a consultant, to come in and look at the new standards. So they hired somebody as a result of all of the, basically all the grief they had been getting from everyone and the cases that had been filed. They filed a consultant to come in and look at their new standards and the tool that they had developed to see what sort of effect it was having on these children. And as a result of that, as of December of 2020, those regulations have now been changed and they're not back to exactly what they were previously, but they are extremely less restrictive than they were. And all of the families that we're aware of that had been previously kicked off are now fully back in Medicaid waiver grace. So they all have Medicaid waiver back. That's my quick story.
Thanks, Anne, and thank you everyone for bearing with us as we roll through I think this is our first technology glitch for the year, actually. So just when we figured out how to share slides. So after we hear from Keegan, then I'll jump in and then have some questions for you and Keegan about what you've shared. Keegan, you should have the ability to advance slides now.
Oh, yeah, I do. So we have seen such crisis over the last year due to COVID-19. And although the pandemic offered us opportunity for population health advocacy, and we certainly engaged in pandemic-related population level advocacy, sometimes it's man-made crises that offer additional opportunity. So one example of the population health work that our MLPs have engaged in over the past year concerns the consolidated cases now known as Cochran v. Gresham and Arkansas v. Gresham. So the background is that in 2018, the Trump administration provided guidance that it would allow states to impose work requirements and volunteer requirements for Medicaid beneficiaries. Now, similar to what Anne was talking about, they accomplished this by waiving Medicaid eligibility requirements. As an aside, on the face of the guidelines, this was actually a little bit exciting for those of us that study health policy and health justice, because here was CMS expressly acknowledging that employment, unemployment, and social interaction are potential health related social needs that can be addressed as structural determinants of health. Now, they misstated the evidence somewhat, but that is a discussion for another day. So by the time their approval, the approvals to add work and volunteer requirements were sought and granted, only one state, Arkansas, managed to implement the requirements before the pandemic struck. Now, the work requirements had a measurable and devastating impact on access to care, with roughly 1 in 4 eligible recipients losing coverage in Arkansas. And so several courts halted implementation. Undeterred, last fall, Arkansas and the Trump administration both asked the U.S. Supreme Court to review the matter, and in early December, the court agreed to do so. We decided to weigh in through a friend of the court brief and amicus curiae brief, using narratives of physicians and patients and attorneys to show the administrative obstacles to obtaining and maintaining Medicaid coverage, even without work requirements, which is the case here in Texas. So this is the cover of our brief, which we filed this past February. Now, our argument was that qualifying individuals already face substantial administrative obstacles to accessing the Medicaid benefits for which they are eligible. In a non-expansion state like Texas, most Medicaid beneficiaries are members of highly vulnerable populations that match the federal floor, like pregnant persons, persons receiving supplemental security income, persons with breast or cervical cancer, Medicare beneficiaries, and persons receiving cash aid through the Temporary Assistance for Needy Families program. For these populations in particular, the Medicaid application process itself presents multiple obstacles to accessing care. And the appeals process, if you're denied, presents another set of administrative obstacles to coverage. For instance, in Texas, renewal requirements must be met as often as 5 times per year, including 4 months in a row. And so even once applicants qualify for Medicaid, they must continue clearing administrative hurdles to maintain that coverage. Now, notably, in expansion states, work is already part of most Medicaid recipients' lives. Nationally, more than 60% of non-disabled, non-elderly recipients work full-time or part-time, and a whopping 94% of Medicaid recipients nationally either have enough hours or qualifying activities, or they're exempt from reporting, usually because they've been found disabled by the Social Security Administration and are unable to work. So in other words, what we argued was that the reporting requirements alone add administrative obstacles to coverage that may disqualify otherwise eligible working recipients and that undermine holistic efforts to ameliorate health disparities. These unintended consequences that stem from existing administrative obstacles to coverage caution against layering on additional reporting requirements. Now, oral arguments were set before the Supreme Court for last week, but the Biden administration had indicated that the results of Arkansas's implementation, as well as the advocacy on behalf of Medicaid beneficiaries, meant that revisiting the waiver approvals was appropriate. And the cases were held in abeyance as of yesterday. But our efforts had an additional purpose. It was our express intent to lift up medical legal partnership. So first, amici are medical and legal organizations that collaborate following the national MLP model. This includes Texas Legal Services Center and 2 of its distinct medical partners, because we have more than one medical legal partnership, People's Community Clinic and Texas Health Action, doing business as Kind Clinic. And we engaged the University of Texas School of Law Supreme Court Clinic, which allowed us to both teach students about health justice as well as multiply our limited capacity by having students do the research and some of the writing. Second, we noted that MLPs developed in part because of the administrative burden in legal programs that were truly designed as a direct response to health-related social need. Third, We shared this advocacy space, one that's typically reserved for a select group of lawyers and professional organizations with professionals who have boots on the ground. And we use narrative to give depth and meaning to the lived experiences of Medicaid patients and the MLP clinicians and attorneys who assist them. The clinicians and attorneys are identified by name and credential within the brief. Finally, we described how work and reporting requirements threaten to frustrate other federal initiatives, specifically pointing to federally qualified health centers, which take a holistic approach to mitigating health disparities in vulnerable populations, including those covered by Medicaid. We explained that FQs are correctly required by law to assist patients in establishing eligibility for federal, state, and local programs that provide or support medical, social, housing, educational, and other related services. But of course, FQs can better fulfill their federal objectives by focusing, for example, on obtaining healthy living conditions for a child with asthma that's worsened by the presence of mold in the home, rather than using limited human resources assisting with appeals of Medicaid benefits that were terminated due to administrative compliance barriers in work programs. Now, there's a few things that you should know before you engage your medical or legal partners as co-amici. There we go. First, there is no categorical prohibition on the filing of an amicus brief for medical or legal entities. Now, on the legal side, this work should be documented as a matter and not a case. But do note that the Legal Services Corporation Act bars staff attorneys from undertaking class action suits, class action appeals, and amicus curiae class actions as the representative. This includes acting as amicus, as co-that's related to a class action. And so you'll want to read your procedural history carefully. In the instant case, there were references to an intent to request class certification in one of the classes preceding to the case that ended up at bar before the Supreme Court, but there was never actually a certification order signed. And then lastly, consider state requirements. I think it may be cut off on the slide, but in Texas, for instance, we have some state-specific requirements, which really matters for an organization like TLSC that's not actually directly subject to the Legal Services Corporation Act. But these state requirements don't have any prohibition on amicus briefs, although they do bar class action involvement. I've provided some secondary resources as well as regulatory references that you may find helpful. Thank you.
Thank you, Keegan. So I want to start with a question for Ann, and then Keegan, I'll get to a question for you. Then I actually want to come back in the general Q&A and continue the discussion. First, Ann, you talked about the regulatory change that came about after the litigation on behalf of the individual clients. And that regulatory change occurred again with regard to the HCBS waivers. What other opportunities do you believe there might be for continued improvements with regard to those waiver beneficiaries?
I think there needs to be improvement in the regulation, not only in the regulations, because right now they still, when the whole thing started in 2015, the regulations for adults and children were the same. And when they changed the regulations in 2019, they actually split out. And so there are still differences in requirements for adults and children. When they changed them in 2020, they did not merge them back again. And so there's still differences in what's required for an adult and what's required for a child to receive Medicaid waiver. I'd like to see those more akin to each other so that there aren't different standards for children and adults.
Mm-hmm. Thank you. And Keegan, let me transition to a question for you. Why do you think population health is an important perspective for reducing that civil justice gap?
Yeah, so, we know that access to counsel is independently correlated with improved community health. And borrowing, I think, from this this population health perspective gives us a mechanism for understanding opportunities for really thinking about moving further upstream in addressing the need to increase access to justice. But it also allows us to pull in and to work collaboratively with our clinician colleagues, for instance, with our public health colleagues, to really unsilo ourselves in a way that respects the fact that our lived experiences is not just as a client any more than it's just as a patient, right? We're whole people. And so I think there's just a real opportunity in really in unsiloing ourselves and borrowing from the learnings within population health.
Which is a perfect place to pause for a moment. I'm going to hold some additional questions I have for both Keegan and Ann so that we can then segue into exactly what James and Becky Sandefur are going to be talking about, or James Teufel and Becky Sandefur will be talking about today. It's really tapping into those other professions, those other stakeholder groups, those other disciplines to really expand our reach in the medical legal with the medical legal partnership approach. So James, I'm going to make sure you or Becky have the ability to go ahead and advance the slides on the screen. I see the mouse moving around. Thanks for bearing with us, everyone. Perfect. All yours. Thank you.
Thank you. Thank you, Bethany. So what Becky and I are going to speak to today is some to the access to justice gap, and we'll give one example of how to potentially resolve some of these justice gap issues using the Utah Sandbox. So some stylized facts about things that we may know or may not know. There are variants of MLPs that have emerged through time. And so this is a simplistic version of what I've seen occur in MLP over the last almost, 20 years, approaching, right, 15 years or so. MLP version 1.0 was focused a lot on establishing formal agreements between legal organizations in medicine and trying to get lawyers perceived as a supplement to what medicine can do. When moving to version 2.0 of MLP, it was more along the lines of figuring out better, more efficient payment sources to fund MLPs, to get people to accept, like I think Bethany led off with, right, that lawyers are an integral part of the medical team. And then this idea, which I think Ann spoke to, is how do you react with legal services when there are these health issues that emerge among people? Arguably, those models must continue, but there's also MLP 3.0, which is a little bit different, and I think will tie into the talk that Becky and I will give today. So MLP 3.0 agrees with 1.0 and 2.0, but it says that we need to look at policy and regulatory reform on the health side, certainly, but also on the legal side as well. And not just saying that attorneys are an integral part of the medical team, but saying legal services are health services. And going beyond just the reactive service model and trying to figure out how do we get to the proactive legal service model as well, because in part we know that there are a whole lot of events in people's lives that aren't dealt with solely through the reactive model. And if we want to get to population health, that'll be an important concept. Great. So I'm going to scroll through here. So one of the things that we see is that through time, the number of attorneys in the United States has increased. But there are other narratives around that too. So it's not just about attorneys increasing per se, but the thing that a lot of people are talking about when they're talking about MLP is not just attorneys, but attorneys that have some public service focus. And when we look at attorneys overall, since the time MLP began to now, we see attorneys in the US have increased. But the proportion of those attorneys who focus on public service or legal aid or public interest or whatever terms we want to use has remained about the same. So despite an increase in attorneys, the public interest attorney or public service attorney has stayed about the same. If you want to get depressed, people like to talk about LSC funding. And something about LSC funding is that it hasn't changed much. And arguably, if you adjust for inflation, it's probably decreased since the time MLP began to now. Now that's the story of depression. If you wanted to be depressed, always look at the LSC numbers and make a point that things are dropping or attorneys aren't changing. But there are other points of hope. It isn't really a question of money or funding. It's a question of, on the right to this slide, of what are the values of people and populations, and how do we organize and use the resources that we have. So certainly from the LSC Funding legal services perspective, the LSC budget line from the federal government has not increased all that much in many years. Several years back, I proposed an analogy to try to understand the values of people in spending. So at that time, several years ago, the analogy was that we spent slightly less on Halloween costumes for pets than the federal government allocated to legal services in this country. Now, again, if you want the depressing story, that was several years ago. Now the position is worse. It's not that we're spending slightly less on Halloween costumes for pets today. We're actually spending more on Halloween costumes for pets today than we are on legal services at a federal level. Now, again, a language of hope. We see two lines going up. One of those lines going up is the Halloween costume expenditures for pets. The other line that's going up is non-LSC funding that supports legal aid services, right? This is a language of hope. And it's also a language that links right to what a lot of MLPs do to drive money differently, not just from the federal budget line, but other budget lines to support legal work in the United States. So I will now kick it over to Becky, and I'll advance the slides to Becky.
Okay, I trust you.
Perfect.
So if we step back from service providers, whether we're thinking about lawyers or doctors, what you see is that there's an enormous amount of civil justice activity in the US that also interlinks with health. So over the past 2 or 3 years, we've been lucky to have 3 nationally representative surveys of the US public and their experience with civil justice problems. And one of them that's a handy one to look at is from the World Justice Project. And it tells us that if you're thinking about a 2-year period, somewhere between 1/2 and 2/3 of adults will have at least one civil justice problem during that period, and that those can be quite consequential. So the most common sort of collateral consequence that they have is the 19.5 million health problems that people experience as a result of their civil justice problems, but it also leads to problems with livelihood and other forms of income, with housing, with their relationships, and with substance use. And if you think about disability-free life years or happy, joyful, healthy life years, and you draw an analogy to experience with civil justice problems and the hardships that spin off from them, people in midlife right now, if nothing else changes, spend about 40% of the rest of their lives experiencing one or more civil justice problems. And people who are starting out in their adult lives can expect to spend about 1/5 of their lives dealing with hardships that come from those problems. So they're very widespread and they're quite impactful, and they intersect very clearly with health issues. We can advance. I'm going to keep talking. So if you move to a specific context, which would be a state like Utah, you can calculate, if you have different kinds of public surveys or other sources of information, the number of unserved civil justice problems that people experience, and you compare that to existing services. And so if you do that for Utah and you look at the problems of small businesses, which are very, very common, the problems of low-income populations, which this group would be very familiar with, and the problems of middle-income populations, which are also quite substantial. What you see is that in any given year, Utah's got about 2.4, 2.6 million unserved civil justice problems for those populations: low-income folks, middle-income folks, and small businesses. And if we continue with the models that we have, so that's legal services provided largely by lawyers, we would need to increase what we're doing now by 15 times to meet the unmet legal need for people. We need to double it to meet the unmet legal need for middle-income folks, and we need to triple it to meet the unmet legal need for small businesses. Those are massive structural changes in doing what we're doing now in exactly the same way. And so it's an opportunity to think about perhaps there are other ways we could structure things that might be easier to scale up than what we do now. One of the things that we know from recent civil justice research is that if you're a legal services provider of any type, you're sitting at the top of an enormous iceberg. And on a really good day, a quarter of civil justice problems are making it up to those providers. This is all the providers across the justice system, not just lawyers, but also courts. And at least 3/4 are not making it up there. So there's an enormous amount of activity, some of which probably we would all benefit if it got some service, that's not getting it now. And if you think about that previous slide, we have to increase what we're doing now by massive proportions to meet that. So in Utah, what they have done is set up an experimental space where they release 2 rules selectively and then monitor what happens with the entities where you've released those rules. So one rule is if you're an ABA maven, you know about rule 5.4 and you recite it to yourself in your sleep, which is that people who are not lawyers can't make money off the practice of law, essentially. And then every state has rules about the unauthorized practice of law. So in some states it's criminalized, in some states it's not. But people who are not lawyers both can't say that they're lawyers, but they also can't do what lawyers do. They can't give legal advice or peer represent you in negotiations in a legal sense and so on. So in the Sandbox, organizations can apply, and they could be market-based organizations or nonprofit organizations, to have some or all of those rules lifted for their activities. So they can have non-lawyer ownership, they can have social workers giving legal advice, they can do a range of different things. And then the consumer protection issue, which we currently handle by unauthorized practice, is handled in the Sandbox by monitoring using data what actual consumer harms are experienced. So it's a back end way of looking for monitoring for consumer protection rather than a front end way. Unless you think this is totally crazy, because it is kind of wacky. We do have research from other jurisdictions that shows us that non-lawyer practitioners of legal services can be as or more effective than lawyers. So the United Kingdom, as some of you may be familiar, had for many years one of the most generous legal aid schemes in the world. So people up into middle income could get full or partial subsidy for their purchase of legal services from the private practice bar. And as they were thinking about pulling that back, because it's obviously very expensive, they were thinking about other kinds of providers that could fill the gap that they knew they would see when they pulled back funding for lawyers. Well, in the UK, since forever, it's always been possible for non-lawyers to give legal advice. What's restricted to attorneys in the UK is actually quite limited. It's rights of appearance in some different kinds of places and the swearing of oaths and certain kinds of documents. But everything else is not restricted to attorneys, particularly legal advice, assistance in filling out documents, and so on. So people have been doing that for pay and for free in the UK for a long time. And they did an audit study where they took random samples of the work product from the lawyers and the non-lawyers in a range of civil fields, immigration, employment, benefits, different kinds of things. And they had peer reviewers evaluate that work to see whether it was good. And the first thing you see is that everybody makes mistakes. So about 20-25% of the time, the lawyers screw it up, and 25% of the time, the non-lawyers screw it up, which means that 75% of the time, they're both doing adequate work. There was another really interesting study or finding that came out of that study was that the non-lawyers were 6 times as likely as the lawyers to do excellent work. And it's because they tend to specialize in whatever it is that they do. They tend to specialize in helping people attach to benefits or specialize in people in dealing with landlords or whatever it might be. So there's clearly a lot of potential for new kinds of providers to offer services that are really good, as well as hopefully being more accessible, less expensive, and so on. And I will hand it back to James.
Perfect. I appreciate it. Thank you, Becky. So to elaborate and to give a really quick example of what the Utah Sandbox looks like, it's linked to the Utah Supreme Court, and the Sandbox is overseen by the Utah Office of Legal Services Innovation. So how this process works is an entity from the outside that meets certain criteria. If you have a non-lawyer who wants to provide legal services, if you want to have a different ownership or management structure, they apply to the Sandbox. The office then reviews those applications. It then submits a recommendation to the Supreme Court. The Supreme Court then authorizes or denies in whole or in part that recommendation. If an entity is authorized, they collect data, they submit that data to the office on a periodic schedule, usually a month or a quarter. The office then monitors that data for markers of risk, of harm, or data quality issues. Then after a period of satisfactory sort of showing of no harm and submitting reasonable data, an entity could apply to exit the sandbox. The Supreme Court then reviews that recommendation for an entity to be authorized to exit the sandbox. If they do exit the sandbox, they then become a licensed legal service entity, still reporting some information to the office. And these things are important. So there's more interest in the public health world. The idea of the access to justice gap has been very well known in the legal service realm for a long time. But in the health world, this idea is starting to get more traction, this idea of legal services deserts. We know that if we look at the old school aspirational interests of LSC, that there was an interest to have 2 attorneys for every 10,000 people eligible. That aspiration hasn't been met. Currently, there's only 6 states where half of that aspiration has been met. So there are a lot of legal service deserts. And if we believe that legal services are in part driving these inequities in health, right, we probably should figure out better ways to resolve some of these legal service inequities to address health inequities and to try to get some of the scale and scope of this. Right, a lot of times I've heard a lot of talks where people look at the health metrics of where do we rank compared to other nations. And we know we don't rank well with regard to various health metrics. What people may not know as much about are where we rank with regard to basic access to justice or legal service metrics in this country. So the old analogy I used to give was that we are just above Afghanistan in our access and affordability to civil justice. We've fallen behind Afghanistan a few years ago. We're now 109th out of 128 nations, right between Honduras and Bangladesh, with regard to access and affordability to civil justice. And the new metric that has caught some traction is a lot of people think about discrimination in the justice system from the criminal justice side. The United States ranks 115th out of 128 countries in discrimination on the civil justice side, right? So if we believe that attorneys or lawyers are health providers, we believe that legal services are health services, and we also probably believe this idea that the civil justice system is a major structuring force for our health system. One of the ways we're going to walk towards health equity is to figure out how to create a better, more equitable justice system, especially on the civil justice side. Great, thank you.
Thank you, James. Thank you, Becky. Ready for some questions?
Sure.
All right. So first of all, Becky, I'll start with you. You know, it really seems like these social problems and life events are very much justiciable issues. So for those who are not necessarily lawyers in the audience, excuse me, those are the issues that can be acted upon through using the law as your remedy. But most people in the general public just don't know what to make of the justice system, how to perceive of it, what lawyers can provide in terms of a solution to their problems. I mean, this is what we do when we provide medical legal partnerships. Part of what Ann or Keegan in the field are doing are providing those trainings. So how can a life event and a legal need, those chasms, be best understood? Is it about raising public awareness? I always talk about like really looking at the need to just simply educate the public so that they can understand what a legal problem is. Let's start there.
Great, those are great. That's a great question. I think there's definitely a place for public education. It turns out it has to be really, really targeted. So people experience these problems as things that happen in their lives. And so if you can design a campaign around security deposits, because everybody knows what that is and most of us have had to pay one, but you can't really design a campaign around know your rights in a huge way because it's just too big and too abstract. So there are opportunities there, but they need to be very focused. Another thing that we know works really well in raising awareness is placing services so that people can't help but bump into them, right? And so that's part of what the genius of a medical legal partnership is. I come in because my kid has asthma, and then I discover that there are conditions violations in my apartment and I can get them fixed using law. One of the things that these regulatory opportunities open up are both new kinds of partnerships, because you can create organizations where the relationships between the lawyers and the non-lawyers are different and more expansive than they are now. but also ways of kind of, if you want to think about the unbundling metaphor from law, unbundling part of what lawyers do and giving it to community health nurses or some other kind of actor who can't do any of the practice of law right now. And I think that's another really promising route, so that people can't help but find help because it's embedded in places where they're already going.
Mm-hmm. And then what about how those services are regulated? Becky, I don't know if you want to just add on to that, in addition to raising the public awareness and making folks just see it, right? So it's ingrained in our everyday lives. Is there a way about the way, rather, is there a solution available with regard to how those services are defined or regulated?
I think once you let lawyers and things and people that aren't lawyers form new kinds of partnerships, it can not just create this sort of co-location dynamic that makes it easier for people to find help, it can make it easier for the services to be organized around the problem.
Yeah.
So you can move to a model where instead of the information sharing being governed by the different disciplines, it can be governed by the person's wishes. So a person can say, yes, you can share information from the physician to the lawyer and so on. In ways that I think would be much smoother than some of what you all run into now.
Agreed. James, next, thank you. And James, the next question is for you. You showed on the screen the graph comparing the US in terms of a lack of access, affordability, all the disadvantages. So if you can, tell us a little bit about how the US health disadvantage is linked to the civil justice system overall, and what we see in terms of lack of access, as well as that other statistic regarding discrimination.
So it's a really big question, right? But one really big answer is, it seems to be about how we organize society, right? And how we organize society has historical roots. We know that there are a lot of examples that research can give us, right? For example, Claire Bambra has published research that supports that if we had a more equitable social welfare system in the United States, we can make up about 3 years of our life expectancy disadvantage. There's other research as well looking at some of these concepts. People like to share the county health rankings, right? Percentages of impact. But I really think it's more around these ideas of how do we structure and organize our society, right? The pushback we often get is we don't have money for that, right? We have, now the reality is we have enough money to resolve all these problems. But the better question is, how do we reorganize our systems to be health systems? And I think the really interesting thing that I see is when we talk about health policy, people get really fixated on medical policy, but we need to, and not just saying health for all, or health in all policies, but what does that mean? And if we look at the civil justice system, which is another amorphous term, but something as simple as legal services, and we see the chasms that we have, there is no way that we can make up the inequities that we have in this country with that civil justice chasm. That'll always be embodied. And so what I've found interesting in the MLP space is, for a long time, it was, I think, just believed that this chasm will just disappear if we just have more money to pay for attorneys. But I think it's going to be a more complex answer than that, right? We will certainly need more money for the attorney side, but we need more money to increase the system as a whole effectively to address health. And we could probably make up the vast majority of health gaps in the US by doing that.
Indeed. And James, when you spoke, you started to go into how complex these concepts are. Same with, where it started with Becky. So I want to actually go now back to Keegan and Ann to tie this back to some of what they talked about. Keegan, if I can start with you first. You highlighted an amicus brief filed on the Medicaid work requirements waivers that took up speed in 2018. Those are extremely hard to communicate legal concepts when you're arguing it in an amicus brief, as opposed to explaining what I talked about with Becky Sandefur, explaining to the public what is Medicaid, what is a work requirement? Now here you are explaining this and utilizing medical legal partnership, the law students, right, to really talk about these legal concepts. So how do you communicate those complex legal concepts, like the substantive argument that you made in the amicus brief, to medical partners to gain their buy-in?
Yeah, this is it's really important, and I remind our legal team kind of constantly to think about the language that they're using. In the same sense, in the health space, we have this notion of health literacy, right? Using language that patients can understand. I think that MLP has to borrow from that as well, and that MLP lawyers are well advised to take that same kind of approach when speaking with clinicians, right? Really smart, highly educated people, but their language is intrinsically different from the language that we use. And so, you know, taking those kind of complex and specialized terms of art and using more colloquial language, describing the impact, using good story and narrative, has been really instrumental for us in terms of communication. And I think the other thing that facilitates that is we demonstrate willingness to adopt their language. So we talk about diagnosing health harming legal needs. We talk about patient panels because there's a caseload and like all of that stuff is very lawyery. And so we borrow their language, and that I think makes our partners more willing to trust us when we say, you know, things like amicus curiae.
Agreed. And Anne, I remember when we prepared for this panel, you talked a little bit, speaking of communications, just generally speaking, what litigation looked like and how the arguments played out through litigation. So I want to go a little bit further though with you, Anne, because you're a pretty advanced medical legal partnership. And I want to just ask you, for the folks who are somewhere at MLP 2.0, perhaps they're even beginning to emerge on that MLP 3.0 concept that James and Becky talked about, or maybe they're in the space where Keegan's at and they're looking at filing amicus briefs. Is there something you would have done differently as an advanced medical legal partnership with the case study that you presented on the open community-based services waiver program? Is there something you would have done differently if you could have?
Oh, I know what you're getting at here. You know, so yes, I mean, it is obviously, we did 5 different cases, and what we told Children's Hospital was, if you have more come in, send them over. But it's obviously more difficult to do 5 separate cases than if, you know, you saw my slide, there was 174 kids that were, and, you know, and I saw other estimates of 200. So, you know, class action lawsuits are obviously something that legal services were not allowed to do under legal services. So when we fight our fight, we do it one case at a time. Other organizations, you know, here in Nebraska that aren't under those sort of restrictions are able to file class action lawsuits, and it's a little bit bigger punch with a lot less work. You know, I was explaining to someone the other day that, you know, on 5 separate cases, when somebody sends me discovery, I have to answer 5 sets of discovery. So yes, there would be easier ways to do it, but we were happy we were able to do it the way, happy we were able to help them at all.
5 sets of discovery. What that screams is lack of capacity, and we saw the graphs and the data shown. James said, don't get depressed by the LOC data or the graphs that he's showing on the screen. So I want to now go back to James and Rebecca and pose the question. Either one of you are welcome to take this. For Anne in Nebraska or Keegan, right, where they may receive certain funding and there are limitations on how they can tackle these big impact cases, but they can only take them on one at a time, and it's resulting in 5 discovery modes individually, one Anne, one Keegan. What are the sort of regulatory reforms that a medical legal partnership can look to trying to carry out? So it's what I'm really trying to get at, James or Becky, is, you know, what we're seeing in Utah. There are about, I think, 4 or 5 states experimenting with this: Utah, California, maybe even a little bit in Washington. Could you talk to us about that regulatory reform that the folks tuned in today might be able to take on, and how important is that in being able to reduce the access to justice gap? Or I am starting to say, not just reducing access to justice, but actually attaining or achieving justice.
Becky, would you like to start?
I'm just going to let you start.
Oh, well, perfect. Okay, I'll start. So I think one of the issues is, right, when you look at these remarkably large system problems, right, if it's a system problem, one of the questions should be, how do we change the system, as opposed to how do we provide services within the existing system, right? So, because oftentimes if a system's inequitable and you keep trying to do more and more in that system, you could end up in a place where you have more inequity down the line, right? So systems that create inequity tend to create more inequity across time. And so one of the things to encourage people to do is think about, how do we allow more flexibility, fluidity to provide legal services to best meet the needs of people? And also for on the attorney side, what is it where we really need the attorney to help in something remarkably complicated, like an amicus brief, where other things we may not need the attorney to do that work, but we have other people who would be fully capable of doing that work. And on top of that, there is one of the things that will be important. It's social contact, right? And if you talk about the most vulnerable people, often they don't have best friends who are attorneys, right? And if we want to get into communities, we're going to have to get people with connections to those communities. There's another element to this too, and then I'll be silent and let Becky speak. But one of the old arguments was this idea of, we just need to get to the lower 10% of folks. That was the old war on poverty argument. And when the war on poverty occurred, that was a reasonable argument to make. If we help people out of poverty, it's also going to help people's health, because the plurality of the health deficit in the 60s and 70s fell to that lower 10%. Flash forward to we stand now, the majority of the health problems, it doesn't fall just to that lower 10%. Being in the lower 10% is 3 times as deadly as it was in the 60s and 70s. But where the majority of health problems are falling is that lower 40%. So we need to come up with systems that also go beyond LSC, because those health harming legal needs are not just falling to the lower 125% FPL or below. It's falling to other people, and social change happens when you get more people involved. And that's how social welfare tends to work well, is including more people.
I would just add a couple of observations that stem from James's, I think, very apt diagnosis of the need for systemic change. So he pointed out the ability to have more flexible ways of providing services and relationships between different kinds of providers. And a Utah-like model is the most flexible, because it says, hey, Ann, you figure out how you want to do it, and you come tell us, right? Because you understand what your service population needs, you understand who your partners are, you here and tell us, rather than imagining that there's some mind that's going to figure all this out in advance and impose it as the next model. So I think that's an important opportunity here. But I think it's also important to remember that there are other parts of the system that we've kept in more or less the same way for 40 years that lawyers control, in a sense, that they might let go of. So when you were talking about the need for capacity, it brought up one of my personal hobby horses about lawyers pro bono. So what is a better use of somebody in a big firm with lots of copiers and paralegals and a lot of energy? Is it helping Ann get through her cases, do the legal work for those cases? Or is it sending somebody who knows nothing about landlord-tenant law down to landlord-tenant court to badly assist one family, right? And so thinking about more rational ways to use the resources that we have, I think, are another important part. And hopefully regulatory reform can give some more space for those kinds of changes too.
Ann and Keegan, I want to give you a chance to respond. And actually, if you don't mind, I just want to quickly note that prior to these remarks, we did receive a comment in the chat box from someone who may actually agree with exactly this. The attendee said, we need to build in a system of well-supervised lay advocates and non-lawyer advocates parallel to nurse practitioners or physician assistants. If there are parts of a lawyer's practice, you can avoid the obstacles presented by having those non-lawyers outside of existing legal practices. So there seems to be some, and I'm just going to skip the rest. I apologize to the participant because I want to give Ann and Keegan a chance to respond, but there seems to be at least some general like receptivity with regard to what is happening in just a few states here that are testing out things like the Sandbox in Utah. Ann and Keegan, we are lawyers. What does this
So
sound
if
like to you?
Well, so I'll respond with, because administrative proceedings such as Social Security, disability, unemployment hearings, those do not require a licensed attorney. And I actually have 2 individuals on staff who are client advocates, non-licensed, that do a majority of my unemployment and my Social Security hearings for me. So I am all over the expanding of capacity by allowing people to do hearings that they're able to do without having to hire additional licensed attorneys. It does expand my ability to do things, and I, would argue that there are times that they probably know more about those areas of law than I do right now.
And Keegan?
Yeah, I would say something similar, which is that we definitely look for opportunities to synchronize with what the health center in particular is already doing. So not carving legal off like it's something special. If you're screening for social needs, you don't need to screen for legal needs. Those should be one and the same. What you need instead, screen for your social needs, and legal is one response where it's appropriate. It is not all of the responses. And that means that your community health workers, for instance, can carry legal information, systems expertise, presuming that you're training them, right? And they can do that kind of, I'm not going to call it counsel and advice. I don't want them applying things that they can't apply, of course, but basic information, they can kind of be a gatekeeper. So I think it's really important to recognize, yes, lawyers are part of the healthcare team. Community health workers, all the way up to the physicians, are part of my legal team. And I think you use them.
I guess I would, my last comment would be, I'm not worried about being out of a job. I'm not worried that if things expand and we find a way to, allow more in to be able to do things like the Social Security hearing, things like that, that somehow I'm going to run out of cases that I can work on. I don't see that happening anytime down the road. So, any outside the box or inside the sandbox thinking, I think is a great idea.
Thank you. So I have one takeaway question for everyone. I want to just double check to see with April Daniels on our National Center team, who's behind the scenes working in the chat box and questions box. Do we have anything left from the audience? April, I just want to make sure. And I don't know if you want to unmute and just confirm, and then I'll have the takeaway for everyone.
Hi, everybody. No, there have not been any new questions coming yet.
Okay, thank you. So I have a takeaway question for the panelists, and then I want to let the audience know that, yes, I became aware that the screen share for the slides was on Super Zoom In. And as we are in this weird twilight zone, thanks to COVID in the technology space, my emails with the PDF of the slide handouts to upload to the system didn't go through. So we will definitely be posting and sharing in a follow-up email with all registrants the PDF of the slide deck that was shared, as well as where you can find the recording of today's presentation. So thank you for you all for rolling with these tech punches with us. And we'll have some in the slides. I just stopped sharing it so you can see us and hear from us. We'll have a couple of resources to share. Don't forget to get the toolkit. Before we wrap up, though, I want to ask Ann, Keegan, James, and Becky. We have, speaking of the pandemic, all seen, especially in the housing space, how health and housing are inextricably linked. We've continued to say this. We knew it. Anecdotally, we know it for sure. But what we see, however, is that the risks are also very disparate and the causes are multifactorial, right? It could be a loss of employment income because of the pandemic that caused the inability to pay the rent, or very well could be housing insecurity because it's not a healthy habitable housing dwelling in the first place, and it was only exacerbated because now the landlords aren't coming out, or perhaps the landlords are circumventing all of the moratorium rules and still kicking people out of housing. And it looks very different in different spaces. Nevertheless, for the folks who are in MLP 1.0, 2.0, or 3.0, would you be able to just share, for those who are interested in moving upstream, any tips or advice or golden nuggets on how they can look at the preventative policy work. So in your dream, what is that golden nugget of advice for the MLPs out there who are interested in working on that preventative policy work? Not sure if anyone's willing to take this one on first, please go at it. Start with James.
I'll go. Some examples, right? One example from Philadelphia that I think was just released publicly in the last week or maybe today, is this idea in eviction cases and landlord-tenant cases, right? What can we do? And there's simple changes that can make big impacts on people's lives. So right now we're fortunate enough to have rental assistance money, right? And we know that a lot of eviction issues are really an issue of money, right? And so we have one of the major drivers of why evictions take place. It's the lack of ability to pay the rent. But then there's also the idea of various types of diversion programs. And so if you change simple policies to say to the landlord, if you're going to file a case in landlord-tenant court, and it's an eviction-like case, what you have to do is also file first with this for rental assistance and also for a potential diversion program of some type before it goes to the court, right? So this potentially prevents things that shouldn't be in the court from going to the court and addressing life events as maybe even not legal needs, right? Like to Keegan's point, right? There's a whole lot of things that go on in people's lives. But if we have rental assistance and we can pay your rent and make it go away and put in some sort of other diversion program, then it never even becomes a legal need, right? So it's really addressing those events in a different way. So that's an interesting example in Philadelphia that was just enacted recently.
Thank you. Who shall take a stab at it next? And actually I had a question that I promised an audience member. It just came in and I promised them I would ask it. So I can pose the question.
So one of the things that we do to prevent further problems is when we have individuals who are being evicted and it's a lawful eviction, there's no real merit to disputing, we will work with the landlord to do mutual termination of the lease. So that the landlord says, look, if you agree to leave and I'll give you a specific time period to leave, I will not evict you. You don't end up with an eviction on your record. You don't end up with the sheriff coming and locking you out of your home. Unfortunately, you still lose your housing, but it still is the better outcome in that the eviction stays off your record and it is a moving out when you're able to move out rather than the sheriff coming and locking your door, which is typically what happens in Nebraska.
Yeah, I mean, I completely agree. We take the exact same approach. Short term, it's not the best solution. Long term, it keeps you housed, gives you the ability to find housing, and I think that's really important also. Yeah, and I think building on this idea is really recognizing that MLP is not legal. I will tend to say MLP legal team because I want to remind the entire healthcare staff that they're all MLP practitioners. And I think that opens up the possibilities for doing preventative work, even if it's at the clinical level, right? Clinical practice transformation is critical as well. And I'll give you an example. Cassie Gonzalez is one of our staff attorneys, and she got herself appointed to one of our clinics, diversity, equity, and inclusion efforts, right? DEI. Because as systems experts, we have a lot to bring on that, to bear on that conversation. And so as this transformation is happening, it's happening in a way that is shaped, really, truly shaped by someone who's an expert in those systems. And that gives us a chance to impact, that entire patient population and really the community at large, because that particular clinic means to be an active citizen in the community. So, so I think thinking about prevention at the clinical level as well is really important. And then being comfortable with stepping outside the bounds of just, I got to go to court, right? Just litigation, and really thinking about mediation and collaboration very broadly.
Becky, if you don't mind, could I challenge you with responding to the takeaway as well as a really important question, I think, given the timing. So I'm going to not just pose a takeaway question to you, but also a question that just came in kind of last minute from the audience that I really want to give a platform to be elevated. Here's the question. If there's time for another question, has there been any MLP work to address conflict resolution as a part of the MLP's approach, especially given all of the conflict the country has recently experienced? For example, merging the cure violence model with the justice system and health of our communities with MLP policy-oriented solutions. Becky, did that resonate or make sense? So I believe
It
what.
did make sense.
Okay. Thanks.
So to the first question, if you really want to move upstream, you need to go to the organizations that are doing the work upstream and partner with, which is a hard thing to do because you're already right in partnerships, as wonderful as those of us who are also their own job, right? They're additional task. But any of you who are interested in upstream organizations in the housing space, I would encourage you to go to justfix, 2 words, stuck together.nyc. And they started out helping people make conditions claims, which is exactly part of the work that MLP lawyers are doing. And now they've moved into working with the city to put data together that allows lawyers to file systemic litigation against really bad landlords. They provide a referral service that connects you to the right to counsel that you have in some of the parts of New York City. So those there are already organizations doing that work upstream. We could all magnify the work that we do by getting together and working with them. This question about conflict resolution and MLP specifically, James would know that space better than I do, but I do know that there are, particularly around intimate partner violence, a range of initiatives around the country that are trying to catch people early, like when they come to the health center or when they come to some other community organization, to intervene, to keep everyone out of jail and keep everyone from interacting with the police, but also to give people the resources they need to handle those conflicts in different ways. The Center for Court Innovation in New York City has a 2 or 3 neighborhoods where it has that program rolled out, if anyone's interested in taking a look at that. And then James would know more about MLP specifically.
James, do you want to add on to that before I close this out? And thank you, Becky.
Yes. So I think one of the important things, and this is a little broader than MLP, but it's important. So in the UK, they're also interested in this MLP thing, but they call it health justice partnerships there, right? And I think one of the important points Hazel Ginn recently made, which is we need to focus on what are the effective solutions. We don't need another study to show the problems. We don't need another study to show that women experiencing domestic violence have more problems, that poverty is bad, that racism is especially problematic in the United States. We don't need another study. We don't need another study linking that to health, right? What we need are solutions to resolve those problems, right? And so I think this is a really important point, because I think sometimes the ways of knowing of lawyers, right, they can argue points forever. The ways of knowing through medicine are, but do we have a randomized clinical trial to prove that yet? And the answer is no, because you can't randomize people to domestic violence or not, right? And so I think where we need to stand is not to use the evidence as a barrier for change, but use the evidence that we know to accept certain things and to move towards solutions, because we know the drivers of violence and struggle and health of people. Now we need to change those drivers, which is one of the great points of Cure Violence, was using a public health approach to address firearm violence in neighborhoods. And we need to come up, and that's the beauty of Cure Violence, is a clear solution that people can understand. One of the things that Cure Violence does step away from are all those structural issues, right, that are also linked to violence. But I think that solutions are where we need to be. We don't need another study of problems.
I agree, but I say that, and I'm glad that you as a researcher, Becky also as another researcher, have noted exactly that. Let me start with you two to thank you, along with Ann and Keegan, for joining us today on really what culminated into a conversation that I think will, is the capstone for our 5-part MLP toolkit series for the health center community. But we know, because we know what the audience looks like, invited folks who are really advancing the medical legal partnership approach, not just around the country at different healthcare systems, but also, as James noted, our friends in the UK, Australia, and Canada. So we can't wait to look forward to helping you all build MLP 3.0. We have some upcoming learning collaboratives. I know everyone here on the screen has publications or some sort of opportunities to do additional trainings coming up very soon. So look forward to seeing their faces again, although we are going to make sure we don't overtax our, our experts in the field. But I can't thank you all enough. Ann, Keegan, James, and Becky for taking time out of your busy schedules, serving clients, doing research, and helping us advance the medical legal partnership movement and approach.